Good evening, everyone, and welcome to our webinar tonight, part of the Anglican Diocese of Fredericton's Christian Forum series. We are grateful to have Dr. Phillip Cooper with us tonight, who will be presenting. And it is great to have you all joining us from all over the country. And as we gather, we'll just invite you in the chat feature to let us know who you are and where you're from, just so that we can see where people are gathered from as a way of feeling connected to one another. It's great to see you, David Peer. Clearly, it's not your first time with us, and so you know the routine, and that's great. For those of you who this is the first time, this is part of a series that we've been running with the Diocese of Fredericton, but we're grateful and glad to welcome people from literally all over. I see some folks from Victoria, from Cape Breton, from Alberta, even in Newidgewok. I'm surprised they even have internet in Newidgewok. But it's great to have so many of you from all over gathering with us as we meet. Just a couple of housekeeping things before we begin. There will be an opportunity for some question and answer at the end of the presentation. There's a button at the bottom of your screen that says Q&A with two bubbles on it. It would be really helpful for me to make sure that I see your question for you to use that feature rather than the chat. And so that will be helpful at the end. And feel free as we're going to throw some questions in there, but we won't be dealing with those until the end. This is being recorded and will be available on the diocesan website sometime tomorrow morning for those who would like to replay it or share it with those who you think would benefit from hearing the teaching tonight. So we hope that this is a gift for you. We're glad to have Dr. Phillip Cooper with us tonight. And those being the housekeeping things, I'd like to welcome Nancy Stevens, who coordinates and chairs the team that organizes these forums. And want to welcome you, Nancy, and thank you for the work you've been doing in this series. And I'll turn it over to you.
Okay, thank you. And I share Sean's welcome. It's great to have folks joining us for this. And as Sean said, this is another in our Christian Forum series. And the aim of these talks is to help us as followers of Christ to think more deeply about some of the issues of our time. And so tonight's topic on euthanasia or palliative care is especially pertinent. And we are pleased that Dr. Phillip Cooper comes to us with a lot of experience in this area as he works in palliative care in Antigonish, Nova Scotia. And he is also on track to be ordained in the near future in the Anglican Diocese of Nova Scotia and PEI. And so he brings two perspectives, both the medical and pastoral side to this issue. And you can read more of his biography on the website where you registered for this webinar. And I don't want to take any more of his time. So we're just pleased to have Dr. Cooper with us and looking forward to what you have to share with us tonight.
Thank you, Nancy. Thank you, Sean. And thank you to Archbishop David and the Diocese of Fredericton for inviting me again to speak at one of your functions. It's a pleasure to be here. I wish that I could be there with you in person. What I will speak to you about tonight is, for me at least, an almost uniquely contentious issue in medical practice and I believe also in pastoral care. I first started engaging with this topic 7 or 8 years ago, a couple of years before the law changed in this country from the purely medical point of view. And over the last 5 or 6 years of my theological studies, I've increasingly had to address it from a pastoral perspective as well. A couple of years ago, I wrote a paper for the Atlantic School of Theology entitled The Pastoral Theology of MAiD, and tried to address these issues from the pastoral perspective as well as the palliative care perspective. And in the process of doing that, I came to realize that it's actually relatively easy for me to abstain or to conscientiously object to participating in this process as a physician, but I don't have that luxury, or will not have that luxury, as a priest. And there are a lot of subtleties and a lot of nuances to this debate, but in spite of that, it remains almost uniquely polarizing. And it's very hard sometimes for us to engage with each other and speak to those who have views that are different from our own, whether they be fellow professionals or patients and families. If we could just move on to my slides now, Sean, share my screen. I intend to approach this from the Anglican fundamentals of scripture, tradition, reason, and experience, which we use as individuals and as professionals to develop our own personal ethics and individual consciences. And conscience is a fundamental issue in this question. I will leave you in no doubt as to where I stand on this subject, but each of you has to make your own decision about where you stand and how you will respond when, as inevitably it will, you address this either personally or professionally. I will be asking more questions than I will be giving answers, but I hope I can give you some information which is objective and accurate. I hope to be able to give you a specifically Anglican perspective on this. And as Sean said, I'm approaching this both from a pastoral care and a palliative care perspective, but I'm trying to lean towards the pastoral care, bearing in mind my audience this evening. I have been a physician for more than 45 years. The last 10 have been the most rewarding years of my professional life, working mostly in palliative care, but also in oncology. So I spend all my time dealing with folks who are facing the end of their lives with advanced cancers or advanced disease, and helping to manage symptoms and improve their quality of life, to help them find meaning in their suffering. It is, for me, a uniquely rewarding branch of medicine. This probably won't be news to any of you, but we are all going to die. And most of us will suffer to some extent before that happens, or perhaps in the process of our dying. Suffering and death are part of the normal human condition. I hope that this shows you that I am practicing what I preach. A couple of years ago, I played the title role in Shakespeare's tragedy of Macbeth, and I hope that you can see that my rather sudden demise, when my head was separated from my shoulders, was accepted with serenity and even equanimity. I didn't have time to plan for my final days, unfortunately. So I'm going to ask you to reflect on your own personal experiences. Are you going to die? Have you seen someone dead? Have you been with someone who was actively dying? Have you experienced death in a close family or friend? Have you experienced suicide in a close family or friend? Are you afraid of death in general? Are you afraid of your own death? Can you imagine such a thing as a good death? Do you believe, as I have claimed, that suffering and death are inevitably part of life? So these are the realities that we are dealing with in 21st century Canada. Our society is becoming increasingly secular whilst remaining spiritual. There are many who would define themselves as the SBNRs, the spiritual but not religious, who have some spiritual sense of a higher power and a life to come. We tend to be in denial regarding suffering and death. If someone suffers, if someone dies, someone must have failed in some way. We increasingly, I believe, in the 21st century, compared to previous generations, put high value on freedom of choice, individualism. I would almost suggest to the point of narcissism. The attitudes that I hear when I sit in class at ZFX shock me sometimes, discussing ethics, when I hear people in their early 20s say things like, "I'd rather be dead than disabled. When I'm no longer young, healthy, and beautiful, let me die." We all, I believe, have an obligation to know where we stand on this contentious issue of MAiD. So I'm going to ask you some questions specifically about MAiD. Would you want it for yourself? Would you support patients, parishioners, family, friends, were they to request it? Would you be prepared to participate in the process of MAiD? Should your own ethics trump, pardon my language, or should they be subject to those in our care? Should our ethics be more or less or equally important to the ethics and the consciences and the beliefs of those for whom we care? So when we look at the history and remember that things have changed very recently and quite suddenly and only in small parts of this world, we go back more than 3 millennia when Moses came down the mountain and the 6th on the tablet was, "Thou shalt not kill." 400 BC, Hippocrates said, "I will not administer poison, nor will I advise it when requested to do so." Around 30 AD, Jesus Christ in the Sermon on the Mount upped the ante and said, "Don't even think of killing or you're committing a sin. Your thoughts are as potentially sinful as your deeds." 2,000 years went by with the whole world accepting the ethical, theological, and legal rules that had been established basically back in the time of Moses. Killing was unethical, it was illegal, it was not theologically acceptable. And then, in 1940, in Switzerland, for reasons that I have never been able to find out, the law changed first. And in Switzerland, to this day, a non-physician can arrange to assist in the suicide of another individual, provided they have what are called unselfish motives. In other words, they have nothing personally to gain by the death of the person whose suicide they are assisting. 50 years went by and the law changed in North America, first in the state of Oregon, which legalized assisted suicide. The big changes started in the early part of this century when the Benelux countries, Belgium, Netherlands, and Luxembourg, all within a short period of time legalized assisted suicide. In 2015, the states of Vermont and California legalized assisted suicide. In 2015, while this was being debated in the Parliament in Canada, the UK Parliament, voting on a free, non-partisan vote, almost unanimously rejected a change in the law to permit euthanasia, simply because everyone in the United Kingdom was confident of having access to palliative care. Euthanasia was regarded as being completely unnecessary. The following year, the law finally changed in this country, and in June, the first medical assistance in dying law was passed, and our lives changed, probably forever. when I first was making these presentations 5 or 6 years ago, I was able to say that this is a very small number of jurisdictions in very small countries in Europe and relatively small states in the US that have made this change, and that this is not a cultural change which is taking place as a reflection of development or progress in society worldwide. But on reviewing the changes worldwide in preparation for tonight's presentation, I have discovered that several of the Australian states have now legalized euthanasia, that the New Zealand government held a referendum last year saying that if a majority of its citizens approved of a change in the law, there would be such a change, and that change actually comes into practice this year. And 5 more United States have legalized euthanasia in the last couple of years. And the fact that precipitated tonight's talk, I suspect, was the change, most recent change in the law in this country, which was on March the 17th last month, when after many delays, many of them COVID related, some of them political, but eventually the Senate sent some amendments to the MAiD law back to the House, and the new law was enacted, which is now called the new MAiD law, on March the 17th this year, and I'll speak more to that in a moment. When we look at attitudes towards MAiD, the big divides come around these relatively simple values. Those who are for MAiD usually will use the values of autonomy and dignity. Autonomy means it's my right to decide how I live and how I die. It's my life, it's my death, it's my choice. No one has anything to say about it but me. That's the argument. I hope to be able to put the lie to that before we're finished this evening. The other value that is used, which makes me squirm, I have to say, is the value of dignity. The organization in Switzerland that legalized, that enacted the practical euthanasia law in that country was called Dignitas. The organization in this country which promotes and lobbies for increasing access to euthanasia is called Dying with Dignity Canada. The reason that I react to this is that dignity is our value. We believe in helping people to maintain their dignity under what are often undignified circumstances at the end of their lives, and to maintain their dignity, and to imply that the only way that you can maintain your dignity at the end of your life is to have your life intentionally ended is something which we constantly have to prove to be false. Those who are against MAiD, one of the big divides societally is, and I hate this word as well, religiosity. It's the word that sociologists of religion use to describe people's attitudes towards religious belief of any sort. Those who have a religious faith, whatever denomination it may be, those who have a belief in a God or a higher power are more likely to be against euthanasia than those who do not have those beliefs. So religiosity, the unfortunate word, is an important factor in determining who's for and who's against this. But it's of course not monolithic in any sense. And perhaps the most practical and the most concerning aspect of this whole discussion is that once we establish the principle that it is acceptable to treat someone's suffering by ending their lives intentionally, once that Rubicon is passed, that threshold has been crossed, then we are all on a slippery slope towards a dystopian future where life has relative value and some people may be persuaded that the world will be better off without them. This is the slippery slope, and we have already, in the 5 years since the law has changed, seen that we have slid some way down this slope in this country. And there are lots of reasons to believe that the slide will continue. So the history in this country started really with Sue Rodriguez back in 1995, a woman in BC who had ALS, Lou Gehrig's disease, who went to the Supreme Court of Canada to say that her charter rights were being infringed because when she became physically incapable of committing suicide, she would make a criminal, a murderer of anyone who helped her. When the Sue Rodriguez case went to the Supreme Court in 1995, she lost by a vote of 5-4. So it was very close. Only 20 years later, which in Supreme Court terms is the blink of an eye, the case was raised again at the Supreme Court by Kay Carter and also her co-plaintiff Gloria Taylor, who had the first had spinal stenosis, a severely painful chronic pain condition, and I believe Gloria Taylor also had a degenerative illness which was not immediately likely to end her life. But they went to the Supreme Court with the same claim, and they won unanimously by a vote of 9-0 at the Supreme Court. And the Supreme Court went back to Parliament and told them, in spite of the theoretical supremacy and sovereignty of Parliament over the courts, the Supreme Court of Canada told the Parliament of Canada that they had to change the law because the law was unconstitutional and infringed the individual charter rights of Kay Carter and Gloria Taylor. And the law, of course, eventually changed in June of 2016, and that is what I regard as the end of the age of innocence in palliative care. This year, we finally had the new MAiD law, which was the outcome of Bill C7, which was given royal assent on March the 17th, just a month ago. So what of our Anglican Church? Back in the 90s, when this issue first came up with Sue Rodriguez, the Anglican Church gave serious consideration to end-of-life care, and in its publication, Care in Dying, said, amongst other things, we do not support the idea that care can include an act whose primary intention is to end a person's life. In other words, the Anglican Church in 1998 was opposed to the idea of euthanasia. The Anglican Church revisited the subject in the times prior to the change of the law in 2015, 2016, and produced another document, which I would commend to you because it's a very helpful document when trying to decide how to respond to this issue in pastoral terms. And that document was called Ensure and Certain Hope, which you will find on the Anglican Church of Canada website, anglican.ca. And this is a quote from Ensure and Certain Hope. The societal and legal context has shifted, in other words, since 20 years before. Individual conscience must be followed. MAiD is antithetical to the belief that all life is sacred unless it has become too painful, bleak, or lonely, which I find a very ambiguous statement, which sounds as though it is saying that MAiD is wrong because life cannot be sacred in a qualified way. Life is sacred, period, even if it's painful, bleak, or lonely, was, I thought, the belief. But this shows that there has been perhaps a change, or else the language is perhaps ambiguous and I'm misinterpreting it. We need to offer a ministry of presence, which is a pastoral rather than a moral response. And I'll speak to that a little bit more later as well. The only documentation that has come out since then, and there was nothing for this most recent change in the law in Canada, was the study guide, which was released in 2018, which is also on the Anglican.ca website, in which, amongst other things, it says, Christian obligation is to be a member of the society of which we are a part. It emphasized the primacy of conscience and the inevitability of disagreement in, quote, non-biblical areas. And the Anglican Church does emphasize the importance of compassion rather than judgment, which we can all agree with. But it also uses this word, which is used also by the Catholic Church, accompaniment, which I find a very vague, ambiguous, and slippery word, I have to say. I'm not sure whether accompaniment means continuing to be with someone spiritually until the end, or physically holding the one hand while the other hand receives a lethal injection, whether it involves giving sacraments on the deathbed or not. And there is no clear statement in that regard in the study guide or in Ensure and Certain Hope. In the Book of Alternative Services, we have some choices. The Ministry of Reconciliation of a penitent. One would wonder whether somebody who is decided to go through with this process could truly be regarded as a penitent. The Catholic Church would certainly not regard them as being a penitent. And we also have two other liturgical forms, the ministry to the sick and the ministry at the time of death. I mentioned Roman Catholic positions. I work in a hospital which is in the Christian Catholic tradition, where the Catholic tradition is very strong. In this, the little Vatican of Nova Scotia, and in reading and reviewing the reports that have come out of the magisterium over the last 20 years, coincident with the timing of the changes of the law in this country, in 1995, Pope John Paul II in Evangelium Vitae said, quote, true compassion leads to sharing one another's pain. It does not kill the person whose suffering we cannot bear. True compassion leads to sharing another's pain. It does not kill the person whose suffering we cannot bear. Pope Francis more recently spoke of the fear that we might be becoming a throwaway society. The Canadian Council of Catholic Bishops, in a pastoral statement at the time of the change of the law in this country, said, suicide is not part of healthcare. Killing the mentally and physically ill, whether young or aged, is contrary to caring for one's brother or sister. Okay, let's just go to the legal criteria upon which the law was based in 2016 and a discussion of how it changed a month ago. To be approved for MAiD, you have to be eligible for provincial health coverage. In other words, you can't be from out of province. You have to be over 18. You have to have, quote, a grievous and irremediable medical condition. Now that is legalese. That language would never be used medically, but the legal definition is on the next slide. It must be a voluntary request. There must be informed consent before proceeding. And there used to have to be a 10 clear day, quote, period of reflection between the time of the approval and the time that the procedure took place. That changed last month. That's gone. It always was kind of ignored, or basically the argument was, and I found this very, very hard to understand, people would say, well, we need to move on with the procedure because there is a fear that the patient may die before they get their MAiD procedure. I've heard that said many times. Perish the thought that someone should have a natural death. So what does grievous and irremediable mean? It means that the individual has a serious and incurable illness, disease, or disability. Serious illness, incurable illness, or disease, or disability. It doesn't say cancer. It doesn't say you're dying. In an advanced state of irreversible decline in capability. So you have to be getting towards the end of the road. This is 2016, please don't forget. There must be, quote, enduring physical or psychological suffering that is intolerable to the individual and cannot be relieved under conditions that they consider acceptable. So even though there may be ways of relieving their suffering and making them tolerable, if they don't want to accept those offers of interventions, then that is justification to proceed with MAiD. Natural death must be reasonably foreseeable. We never knew what that meant. Now it doesn't mean anything because that was repealed last month, and I'll speak more to that in a moment. Death no longer has to be, quotes, reasonably foreseeable to be approved for MAiD. There need to be 2 independent physicians or nurse practitioners who give their written confirmation. For people whose death is not reasonably foreseeable, there is a protection in that there needs to be one of the physicians signing off on the procedure or on the approval who is a specialist in the area of diagnosis of the individual whose life is getting to be intolerable. So if it's a neurological complaint, it needs to be a neurologist. If it's a heart complaint, it needs to be a cardiologist. So there need to be 2 independent physicians signing off on this. And there is the opportunity to withdraw consent right up until the time when the syringe is plunged. There was supposed to have been, and this was written into the law in 2016, an independent review before December 2018, which didn't happen for a variety of reasons, some parliamentary, some to do with the pandemic. But there were 3 issues which were supposed to have been reviewed, which were discussed prior to the framing of the law and were excluded at the time, but considered for future. One was the issue of mature minors. If a 16-year-old decides that their life sucks and they want to die, should they be allowed to? Advanced directives. Can I say, if I develop dementia, then I want you to euthanize me because I may not be able to give my consent at the time? That was also excluded at the time, but that is on the very slippery slope as we speak. And the third was mental illness as the sole underlying condition for the application. And that is also about to change. So if you have chronic depression, for example, or perhaps chronic pain as the sole condition for which you're applying for MAiD, it was excluded from the 2016 law, but Parliament said on the 17th of March that it had to be reviewed immediately and reported back by the 17th of March next year in anticipation for a change of the law on the 17th of March the following year, 2023. So mental illness is almost certainly on track to become an adequate sole indication for approval for MAiD. The definitions may be confusing because the language has been confusing. There's no getting away from that. Euthanasia, there are basically 2 types, and this I'm looking worldwide now. The very small minority in this country, although the majority in the United States and in the European countries, it's truly assisted suicide. So a physician prescribes a lethal cocktail of pills which the patient takes home and chooses the time when they actually ingest them. And what has been found is that simply knowing that they have that power to end their lives when the day comes that they are intolerable to them is all that people need to carry on going. And actually less than half of people who have those medications at home, having been approved, will actually go through with the procedure. They just keep them at home. We hope nobody else finds them. We hope they don't get into the hands of children, but they keep them at home and they actually never use them. And I'll leave you to interpret that. One of the problems with the idea of giving people a bunch of pills to take is that if, for example, they do it on their own with no one around, and when they are sedated but not dead, vomit the pills back, and then aspirate or asphyxiate rather than die a peaceful death, that's a problem. And if there's no one there with them to help, that's a problem. The laws that have been framed to deal with that scenario would suggest that there should be a physician present, able to complete the process with an intravenous injection if the patient's own self-administered medication by mouth has failed to achieve its purpose. So this is the minority. This is not the way most people would do it in this country. The majority, it is truly medical assistance in dying, and I'll tell you why I hate that expression as well in a moment, which is by intravenous injection. So an intravenous line is set up, and several medications to first make the individual go to sleep, and secondly to stop breathing, and then third to die, are given in a controlled setting. And I'll show you how that actually happens in a moment. I noticed just at the beginning of this presentation that the image that we have used for this talk shows an arm or a hand being held, which is very much palliative care. What I didn't notice until we were just preparing this evening is that there's an intravenous line in the same arm, which is not something you would see in our palliative care unit. The intravenous line implies something which we're trying to suggest is not such a good idea. So I think that was just a mistake in the image. It was not an intentional message. So the language is confusing, and it has been confused intentionally, I would suggest, to obfuscate some of the realities of this. The right to die movement does not like the use of words like euthanasia and suicide. They have stolen the word dignity, the value of dignity, which is a palliative care value. The very idea of euthanasia in Greek means a good death. That's what I spend my time as a palliative care physician trying to help people to have. Euthanasia means a good death. That's a success for me. That's what we're trying to achieve. And most often we can achieve that without actively ending people's lives. The word has been subverted. And the third expression that's been subverted is the one that's there under B, medical assistance in dying. That's what I do as a palliative care physician. I assist people in their dying. I don't kill them. I spend 95% of my time as a palliative care physician helping people to live, and probably 5% of my time helping people to die. I'm medically assisting people to die, but I'm not giving them MAiD to achieve that. So the language has been, I think, intentionally subverted, and it's really unfortunate how that language has been made more confusing. When you look at the statistics now, first of all, internationally, in the Netherlands, where this really all began on a national scale, as a percentage of total deaths, they started in the early 2000s, as you saw, 1.2% of all deaths in the Netherlands in 2006 were by euthanasia. 10 years later, it had more than tripled to 4.1%. That's the latest year for which I could find figures. In Canada, in 2017, the highest rate for euthanasia MAiD was 1.8% of deaths in BC, and the lowest 0.5% in our Atlantic provinces. When the law changed in 2016, the government instructed the ministers to report on an annual basis on MAiD in Canada to see how many people were asking for it, how many were receiving MAiD, the demographics, the socioeconomic circumstances, the diagnoses, the providers. Now, the law only changed in the middle of 2016, so the first full year to report on was 2017. The last full year to report on was 2019, before the first annual report actually came out in July of last year. So the only years of completed MAiD availability that we have to compare are the years 2017 to 2019 in this country, and we anticipate the second annual report sometime this summer, which will be including the year 2020. But you will see the trends from the numbers that I will now show you. And I would ask anyone who's interested to go to the Government of Canada website and just see these figures. The first annual report is an interesting document, and it covers a lot more statistics than I can mention tonight. So this is extracts from the first annual report for the years basically 2017 to 2019. The total MAiD deaths in Canada, 2017, the first full year, were 2,833. This is the whole country. 2019, more than double. Total MAiD procedures in New Brunswick, 2017, 47. 2019, 129. 3 times the number in 2 years. Total in Nova Scotia, 2017, 62, 2019, 147. I think you can see where these trends are leading. The average age of those going through completed MAiD procedures was very wide, from a young of 18 to an old of 94, with an average of 73. Why did people request MAiD? Where was it provided, and by whom? 2/3 of the people going through MAiD procedures had advanced cancers. That's not a surprise, I would think, to anyone. There were 10% each for end-stage respiratory diseases such as COPD, end-stage cardiovascular diseases such as heart failure, end-stage neurological diseases, the archetype of which would be ALS, Lou Gehrig's disease. So 10% each, lungs, heart, brain. 1/3 of the procedures were performed in hospitals, 1/3 were performed at home, and a minority of about 20% in palliative care facilities. And I'll speak more of that in a moment. Who did them? The majority were done by family physicians or nurse practitioners. The small minority, 9%, by palliative care professionals. Now, the 2 national bodies that speak for palliative care are the Canadian Society of Palliative Care Physicians, which is the body to which I belong, and the Canadian Hospice Palliative Care Association. And they have put out a number of joint statements on this in the last couple of years. Last month, there was an article in the Canadian Medical Association Journal entitled "A Unique Milestone." And if you'd like to look this up, it was on March the 8th. This is the opening paragraph. "This week marked a unique milestone in my medical career. I never would have predicted where I now find myself, reflecting on the 100th time that I have provided medical assistance in dying." The article went on to bemoan the fact that more palliative care physicians were not joining in and helping out with this, providing this service. And the Canadian Society of Palliative Care Physicians promptly responded with another statement a couple of weeks later, that's March the 31st, the first statement of which is, "Palliative care strives to alleviate suffering, but does not intentionally end life. It is internationally and nationally recognized as a practice distinct from MAiD." I'll just finish that slide. The numbers of people actually completing requests you can get an idea there. In New Brunswick, it was 77%. So these are the number of requests, and that means that 23% were denied or died before it could be completed. And in Nova Scotia, it's slightly higher. The Canadian Society of Palliative Care Physicians put out this statement in response to that article, saying, MAiD is a healthcare system responsibility. In other words, it's not a palliative care system responsibility. Physicians must have their conscience rights protected. MAiD must be a patient-initiated request, and I'll speak to that a little more in a moment. And MAiD and palliative care are distinct practices. When the law was about to be changed back in 2015 or so, it was just assumed by politicians that the palliative care folks would be the ones to do this procedure. They're the experts in death and dying. They're the thanatologists who look after people at the end of their lives. But when they actually asked the palliative care community, they were told, this is not what we do. This is not what we are prepared to do. And I'm so pleased that my professional body nationally still puts out statements like this. I fear for a day in the future where there may be a board of that organization that feels differently. But at the moment, it's very clear, palliative care does not do MAiD. So this is what changed last month. Instead of death having to be reasonably foreseeable, there are now two tracks. Reasonably foreseeable, in other words, someone who's going to die within the next month or two, for which there is no longer any period of reflection, if there ever was, and not reasonably foreseeable. In other words, people with chronic diseases like perhaps dementia, but perhaps Parkinson's disease, multiple sclerosis, a host of different diseases which cause chronic misery and suffering, who decide that they want their lives to end. And for them, there must be a 90-day period between the initial assessment, that's the first assessment, and the procedure, a 90-day period of reflection. But even that, when you read the small print, there's a slippery slope, because unless the wording goes, the patient might lose capacity during that time, in which case the 90 days can be shortened. Mental illness is still not yet covered until this review next year, as I mentioned, although neurocognitive disorders, by which we're referring to mostly dementias, are. Senator Pamela Wallin tried to push through an amendment allowing for advanced directives for MAiD. In other words, you could decide that if you became demented, for example, then you would wish to have your substitute decision maker make the decision and consent for your MAiD procedure. That was rejected for the time being. So when somebody says to me, when somebody says to you, I want to die, please help me. Why do they do that? Most people think it's because they're in severe and intractable pain, but that's not the reason people ask for MAiD. The top of the list of reasons for requests for MAiD is loss of dignity. There's that word again, dignity. What a challenge that is to us. Loss of control. Loss of autonomy, these very 21st century values. Fear of the future, fear of the unknown. I spend a lot of my time explaining to people what the possible scenarios they might be dealing with down the road may be as their diseases progress, and helping them to understand what the likelihood is and what the possible but less likely outcomes might be. And that, I believe, helps to allay fears of the future. This is a really scary one, the guilt of being a burden. If I'm sitting in a nursing home, perhaps with a little bit of dementia, requiring full care, not able to communicate with my family, burning up their inheritance, what good am I? Why would my life be worth maintaining? Wouldn't they all be better off without me? The guilt of being a burden, particularly for the vulnerable in our society. And it's no surprise that the disability lobby has been particularly vocal in speaking against the law regarding MAiD. The implication being that some lives are worth living more than others, and some less quality lives would be better being ended. People who are quadriplegic may say, my life is wonderful. I live a wonderful life. My life has value just as much as anybody else's. So we're making these horrible value judgments about the value of a life and potentially risking the guilt of people feeling a burden. One point that I just would like to elaborate on a little before we go on, when it comes to the issue of consent for MAiD, the fact that this must be a patient-initiated request is vitally important, and it's been something which has caused me some discomfort on a couple of occasions, with the feeling that perhaps I ought to be bringing the subject up if it hasn't been raised by the patient. This is what the Canadian Society of Palliative Care Physicians has to say. To safeguard against any possibility of subtle or overt pressure on patients, physicians should not initiate a discussion about MAiD or suggest that the option of MAiD unless brought up by a patient. The expectation that physicians introduce MAiD in the absence of a request from a patient may be all that is needed to push that patient to choose MAiD. In Canada, we have seen many examples in the media, first-hand testimonies presented to Parliament of Canadians who felt pressurized to pursue MAiD by a healthcare professional suggesting it. We urge governments to set policies that reduce the harm to vulnerable patients who may feel pressured to choose MAiD by requiring that discussions about MAiD be patient-initiated. There is a young generation of physicians coming up now who, I believe, are starting to regard discussions about MAiD as just being another part of advanced planning. Do you want to be resuscitated if you have a cardiac arrest? Do you want to die in hospital or at home? Do you want MAiD? It's just another advanced care plan topic of conversation. And I think that's wrong. I feel that's profoundly unethical. So pain and physical symptoms are way down the list of reasons why people ask for euthanasia. Here's another dystopian idea. In Holland, there is the serious suggestion that reaching the biblical 70 years and 10 should be reason enough. I'm 70 years old, I'm tired of life, or I've lived my life, it's time for me to move over and make room for someone else. That apparently could be reason enough to request euthanasia. The ethical values that we refer to in pastoral and palliative care, I don't need to tell you these, but I'm going to raise them nevertheless. Beneficence, non-maleficence, do no harm, primum non nocere, dignity, autonomy. When Kant invented this term back in 1785, his definition was the freedom to act ethically and rationally. So we have to ask the question, is it ever ethical or rational to end a life intentionally? Freedom and liberty, these are very modern but also very old values. John Stuart Mill in the 18th century said, my liberty ends where your liberty begins. And none of us has the freedom to abdicate our freedom to continue to live. So none of us has the freedom to decide to end our lives. Justice, integrity, and these are the words which come into our palliative and pastoral perspectives, the ministry of presence and of accompaniment, but the fear that accompaniment implies complicity. Christian values regarding MAiD, the sixth commandment. St. Martha's Hospital has on the elevators in all the floors its primary value as a hospital which delivers Christian healthcare, respect for life in all its stages. The Sisters of St. Martha, when they handed over this hospital to the government of Nova Scotia 25 years ago this year, had the amazing foresight to include in their mission agreement that St. Martha's would never permit abortion or euthanasia within its walls. 25 years ago when no one was talking about it. Romans, Paul says, we do not live for ourselves alone and we do not die for ourselves alone. The one message that I really want to emphasize is this idea of autonomy is just to me is so wrong. We do not live on our own in this world. We live in community and we die in community, and other people share our lives and may have something to say about how we live and how we die. In Galatians, Paul said, bear one another's burdens. Suffering and death are mysteries, not problems to be solved. The idea that comes partly from the book of Job, that suffering can be redemptive, there can be meaning in suffering, there can be soul making in suffering, and that we're not fully human if we haven't had some suffering in our lives that has taught us lessons from which we've learned and become better human beings as a result. Some of the existentialist philosophers might have said no pain, no gain in a slightly different context, but suffering is not all bad, and some suffering may indeed have redemptive meaning. And ultimately, we are obliged to demonstrate Christian loving kindness, Christian agape. In other traditions, our First Nations brothers and sisters don't talk about death, but the journey from the earth walk to the spirit walk. In Islam, the teaching is that no one has control over life or death, and that there's an obligation to alleviate suffering. In Buddhism, suffering and death are part of life. Suffering results from attachment to impermanent things. For example, life, youth, beauty, health, rather than acceptance with equanimity. Buddhism also talks of taking and giving, taking on the suffering of others with compassion being a powerful means of controlling our own self-centeredness. Ubuntu, much beloved of Archbishop Desmond Tutu, the Bantu philosophy that says that I am because we are. We live together in community. And Leonard Cohen said, there's a crack in everything. That's how the light gets in. Legal and ethical aspects of this. We look at the religious law and the ethics that we're bound by, scripture, other texts, diocesan guidelines. We look at the secular law, secular ethics from our various levels of courts. We look at the professional law and ethics, our royal colleges, health authorities, hospital policies. And we look at our personal ethics, our patient, our family, healthcare, pastoral care ethics, which all of us has to decide about. So what is the antidote to suffering? I'm going to suggest that it is finding meaning in life beyond oneself. And I don't like to speculate about the future, but I must confess that this slippery slope is frightening in palliative care. And it really troubles me to see where we're going with decisions which may result in the premature ends of lives that still have value before they end naturally. John Donne, Anglican priest and metaphysical poet, said in 1624, and I paraphrase, "No man is an island entire of itself. Every man is a piece of the continent, a part of the main. Any man's death diminishes me because I am involved in mankind, and therefore never send to know for whom the bell tolls. It tolls for thee." Thank you.
Wow, thank you, Philip, for that. And thank you for sharing of your experience and your journey through this. Just as we mentioned at the beginning, we're going to have an opportunity for some question and answer of Dr. Cooper. And again, if you can use the Q&A button that's at the bottom of your screen, that will be helpful so that I can notice your question. Given the sensitive nature of this topic, Normally I would kind of read out who's delivering the question, but I won't tonight, just to allow people that freedom to ask questions that they might be a little bit hesitant on. And again, thank you, Philip, for sharing that. One thing I would point out as some questions are coming in, you were correct in noting in the graphic for this event, I did not notice that intravenous line. I was the one to design it. And I apologize for that and will duly note to be more intentional with thoroughly viewing stock images.
I just noticed it as the meeting began, Sean. If I'd noticed it before, I'd have pointed it out to you.
I suspect it's, I shifted a little things for the opening, so that's probably, it was hidden before. So yes, you were quite right. That was accidental and not intentional at all. I see some questions coming in. And so our first question is, what role can there be for parish volunteers to address the issue of MAiD? Is there any way in which things can be done as a parish family?
I would caution palliative care volunteers to enter into any discussion about MAiD at all. But having said that, parish volunteers could well do what I do when confronted with either a direct request for it, or more often a rather tangential mention like, I'm done with this, or I don't want to carry on living like this, or this sucks, or I just want to go. Those sort of comments are made. And that, of course, I would not take as a direct request for MAiD. But those sort of comments, for me, should be the beginning of a palliative care discussion. So my response to that is, tell me about your suffering. How are you suffering in your life? What can we do to help relieve your suffering and give your life sufficient meaning that you want to carry on living it? I have had so many experiences over the years of people saying, not I want MAiD, but I don't want to carry on living, and having that conversation, and then unleashing on them the full power of the palliative care team, which I regard as a therapeutic intervention. And we now have studies that show that palliative care actually prolongs lives and improves the quality and reduces the costs of the care of those lives as well. But when treating people for their symptoms and trying to help with their quality of life, people find meaning in their lives and want to carry on living. I've had many really gratifying experiences over the years of treating people's symptoms in very simple ways very often, or helping them with equipment at home or whatever it might be, and then not being able to contact them for the next couple of months because they're off living their lives. And then when their lives eventually do come to a natural end, I've had people say to me, thank you for the gift of those months that I didn't think I wanted, because I've managed to do wonderful things, a legacy, memories, family, reconciliation, whatever it might be. And now my life is ending naturally, and those months were precious, and I'm leaving behind a legacy of wonderful memories, which I wouldn't have had and I didn't think I wanted. So that's the sort of, those are the rewards of palliative care.
Thank you for that. And I neglected to mention, and I will do that now. Also, Philip would invite you to stop screen sharing so we can all see you.
Sorry.
Fuller. I recognize there may be some questions that, given both your current medical practice and your future ministry, may cause some conflict. So I want to extend that freedom to you, Philip, to say, great question. I'm not at liberty to comment on that. I want to make sure you have that freedom, and our guests know that as well. Another question for you, Philip. Do you think we're doing all we can in the area of palliative care?
Certainly not. I mean, one of the good things that's happened, the the lining of this otherwise big black cloud for us has been that when the law was being discussed in 2015, 2016 in Parliament, it was pointed out that all this energy was being expended for the care of the 1 to 2% of the population that might be interested in requesting MAiD, whereas nothing was done to guarantee access to palliative care for the 90% of us who do not die sudden deaths and therefore have an opportunity to prepare for the end of their lives. And there's something wrong with that picture. And so out of that debate back in 2016, eventually came what's called the Framework for Palliative Care in Canada, which has certainly advanced the agenda of palliative care. And people are realizing more and more what palliative care means. It's not just end-of-life care. It actually means helping people with quality of life in often quite simple and inexpensive and low-tech ways. So palliative care has paradoxically, ironically, has benefited in parallel with this move towards acceptance of MAiD. But we need to keep the two quite separate, as the Palliative Care Society emphasizes. And one of the other reasons is that for many people, palliative care is a tough sell to begin with. I nearly always have to explain to people what palliative care means now, because most people know when they're referred to palliative care, it means there's nothing more that can be done. I'm dying. They're done with me. That's what palliative care used to mean, and sometimes still means in parts of this world, unfortunately. But we need to keep MAiD quite distinct from palliative care, because it will be even more possible for people to fear palliative care just as a road to euthanasia.
In speaking of picking up on that, do you think euthanasia or MAiD will be a slippery slope to the forms of eugenics in a truly dystopian future, one that did occur in the 19th, 20th, and 21st centuries?
I hope and pray not, but it's impossible to say that it's impossible, because that you see how rapidly the acceptance of MAiD is accelerating, and it's reasonable to assume that there will be twice or three times as many this year as there were last year. But it's the point that I really wanted to emphasize was this principle that once you cross that threshold of saying it is acceptable to intentionally end the life of an individual in order to relieve their suffering, then any suffering is up for grabs. Any suffering is potentially going to be a reason. And at the moment, it's only accessible to individuals who actively ask for it. But there are these gray areas with the vulnerable in our society where they may feel pressured or compelled, or feel that they are a burden, and that the right thing for them to do is to volunteer themselves for it. That's my fear. That's where the slippery slope, I'm afraid, is taking us already.
Do palliative care doctors not have a financial conflict of interest in their decision not to support a patient who wants MAiD? Do you think, or would they be put in touch with doctors who will assist them in obtaining the same?
Whoa, I didn't go into this for the money. I never even gave that a thought. The only I can't even think what financial impact it would have, selfishly as a palliative care physician. No, to answer part of that question though, Sean, if somebody asks me, and occasionally people do, most people know my views on this, and so I don't even get asked. But when people do ask me, and it has happened, I am obliged to make what's called an effective referral to someone else. I am allowed by the law to say, I'm sorry, I conscientiously cannot help you with this, but I am obliged to continue to care for you until I can find someone who will. And so that's my obligation. And in practice, that's what happens. But I mean, I can't. The financial thing I think is frankly completely irrelevant. I'm paid by salary, and it doesn't change my income whether someone gets MAiD or not. The people who do the MAiD procedure would be paid a fee for that service. But as a palliative care physician, I have no financial interest.
Well, another question came in, and it slightly kind of picks up on that. Do you think that in the future that healthcare savings will be a motivation for encouraging this?
That's a fear. That's a real fear.
Yeah.
That's a real fear. We can't afford to continue looking after you. Might be the argument. Healthcare is too expensive. If you don't look after yourself, society is not going to look after you either. And that's getting perilously close to eugenics, as the previous questioner mentioned. But at the moment, fortunately, we don't have that rationing. But as healthcare becomes more technical and more expensive, it's not inconceivable that we may have to make those sort of decisions. And there would be terrible ethical choices to have to make. And I'm very glad that I won't be one who would ever have to make them.
Question that relates with regards to pastoral care work, and particularly regarding accompaniment. When a person adamantly insists on MAiD, how do we determine whether to be there with them at the time of dying? Do you think this is giving support? And any thoughts on, I guess, again, from a pastoral care perspective, what might be said at the funeral?
I think that the message that I've tried to give is that this has to be an individual conscience decision. The guidance that we get from the Anglican Church of Canada tells us that it's individual conscience that's paramount, and that it's individual choice as to how that's actually played out. I don't see anything in the Anglican Church of Canada website that says that, for example, sacraments of reconciliation should not be given to those who are going through with this procedure. But I think, I know after reflecting for this pastoral theology of MAiD paper that I had to do at AST a couple of years ago, I said that it's relatively easy for me as a palliative care physician. I can just say, I'm sorry, I can't do that. I have to find someone who can. But as a priest, I would feel obliged to accompany, even though I was strongly conscientiously opposed to what was happening. But the emphasis and the language that's used by the Anglican Church is a ministry of presence. And also the language of compassion rather than judgment. And those are the things that I would have to use as a guide. But I dread the day, although I know it will come, when I'm holding one hand and the other hand is receiving a lethal injection. I will feel complicit, however much I'm able to express my disapproval. I can see perhaps that the church will have to do something similar to what the medical profession has done, and allow those who are strongly conscientiously opposed to opt out of doing this and saying, no, I can't, as your parish priest, be with you for the procedure, but I'm obliged to find someone who can be there. I can see that as a possible solution. But I have had conversations with several priests over the last 5 or 6 years who have been extremely distressed by feeling that they could not abandon their parishioner at the end of their life, and had to be seen to be participating in something with which they were strongly opposed. And that causes amazing, extraordinary ethical distress.
I can imagine. I can imagine under normal circumstance, I would create the distress, but then also given that, very soon, and I mean, realistically, you already are, for all intents and purposes, wearing that dual hat of being in ministry and also being a physician. So yeah, that would be an incredibly difficult pull, I would think. In your presentation, you mentioned the concern about it becoming MAiD becoming more common and more accepted with younger, less experienced practitioners. Do you, in your opinion on that, is that based on what you're seeing being taught in terms of training now, or?
My suspicion, my fear is that there is a societal generational change taking place as we move further into the 21st century. Post-millennials, who are less likely to be religiously persuaded, as most of us are, and therefore the religiosity part is taken out that I mentioned earlier on, do not necessarily share these values of life being precious and sacred, as Albert Schweitzer would have said, to the very end, the very natural end, but feel that if life's just not good enough to continue, then it should end, and people should have that option. I have had a couple of priests who've said to me that their parishioners who had family physicians for many, many years, the family physician retired and a young family physician came in to look after them and said words to the effect, well, you've had chronic arthritis or chronic pain or chronic depression or whatever it might be. Of course, you realize you now have a choice. And the patient recoiled in horror and said, what do you mean? That's not what I'm asking. That's not what I'm looking for. Why would you raise the subject? That's not what I want. But the fear would be that from the physician's perspective, that they would be at fault if they didn't raise the subject themselves. We had a legal discussion about this whole concept of whether or not it should be raised as part of informed consent, as just another option, another management option. And I was asked, Dr. Cooper, you were once a surgeon. Before you took somebody to the operating room, you'd have discussed all the available options before you got their informed consent, would you not? What's so different about this? And I said, but that's a false analogy. Are you saying that if I'm a family physician who has a young woman come into the office with a positive pregnancy test, that I'm supposed to say, well, of course, I'm quite happy to look after you and your pregnancy, but you realize you have a choice? That's an absurd suggestion. But that's the sort of argument that is being used. I need to know whether this is something you've thought. You realize you can perhaps be considered for it if that's what you want, as just another option in your advanced planning. I fear that that's the way our slippery slope is taking us, and that a younger generation of physicians is more likely, with autonomy as a paramount value, to be persuaded that that's a good thing. That's the way that they should be practicing.
There's a statement here that some transplant surgeons are saying more organs are available for transplant now that MAiD is available. Any comment? I don't know if that's come up in your research or not.
No, and I don't know whether that would be, I think the numbers are so small that it's more likely just the result of the other change in the law, which is to require people to opt out from being organ donors rather than opting in. So there are more organs available from that perspective, but I don't think it's because of MAiD. I have not read anything in that regard.
How do you think it will be handled when a personal request is not needed, or when others can decide in the case of a nonverbal, mentally handicapped person?
I just hope and pray that that will never happen, but I'm afraid that it's conceivable. It's becoming so normalized, even in this short period of time. what's the big deal? People say it's legal. People are allowed to ask for that. It's legal. My nightmare scenario has always been that we have somebody in our hospital who's dying a miserable death, and sometimes people still do, who says, okay, I want MAiD. This is a publicly funded hospital. It's legal for me to request it. You're obliged to provide it. I'm too sick to move. Do it, or else there will be legal consequences. That's my fear, and I'm not the only one to have that fear, but it's just the kind of banal normalization that is happening in only 5 years since the law changed. What's the big deal? People want it, it's legal, there are folks who are prepared to provide it, end of discussion. But it's a different world from the world we lived in before 2015, ethically, I believe. I still believe it may be legal, but as we all know, the legal benchmark is not nearly as high as the ethical benchmark. And for me, ethically, it is still wrong. It has been for 3,000 years. I believe it still is wrong, ethically and theologically. It may not be legally wrong any longer, but ethics are still important. And I still feel that I still profoundly feel that it's ethically wrong. And also, even more banal, unnecessary. I didn't mention this, but one of the reasons that they don't have MAiD in the UK, for example, where everyone has access to palliative care, is that when people's lives at their ends were so irredeemably miserable and they were suffering in a way that could not be corrected, in a way that they could carry on living their lives, there were always ways that we had ethically to help them to die quietly and peacefully, but naturally. Palliative care has always done that, without actively killing them. If the only way that somebody at the end of their life, when they're miserable with pain or delirium or whatever it might be, is to have them asleep, if that's the only way that they can be comfortable while they die, we can do that. We could always do that without euthanasia. So it's almost banal to say it, but it should not be necessary. It should not be necessary.
And you gave the analogy of a moment ago of comparing providing all the options, with chronic illness with a woman finding out she's pregnant. And someone has made the comment to say, back in 1986, this gentleman's wife found out she was pregnant and was asked by her physician if she was okay with being pregnant and wanted to be. So he was just pointing out that, it's been at least since the early 80s where, that false analogy's been floating around and trying to be out there. Keeping on with what you were just talking about, Philip, about the question regarding nonverbal mentally handicapped. I'm not. Don't hear what I'm not saying. I'm not lumping everything together, but someone has made the comment about advanced Alzheimer's who's non-communicative. Obviously mental faculties are not fully in order. Is that being pushed as an option? Like, is MAiD being pushed as an option for either the patient or the family in dealing with that?
Well, it's my understanding that you still have to make a request and give your informed consent. And if you already have advanced dementia, you're not going to be able to do that. The question more urgently is, can I make an advance directive that says if I end up like that, then somebody else makes the decision to proceed on my behalf? And that's a much more likely scenario. I keep coming back to this idea of John Donne's. We live in community. We do not live and die on our own. I looked after many people in the L'Arche communities here in Antigonish, of which we have 4 or 5, who are nonverbal and not contributing to society in any active way, who require a lot of care, but they are living examples of human suffering, which we as fellow human beings help to alleviate. And that makes us as society stronger and better and more human. And when the day comes that we decide that if, for example, you have Down syndrome, that you're not worthy to continue living, or if you have dementia, that you're not worthy to continue looking after, you're just a burden, this world will be a worse place for it. And I hope I'm not around to see that. I really hope I'm not around to see that. But that's where our slippery slope, I'm afraid, in the far distant dystopian future could take us.
What's your thoughts, Philip, on families who insist on keeping people alive by all means possible in the ICU, even though it seems very medically anyway, it seems evident that the individual will never be conscious again?
Well, this is kind of bread and butter for me, because we see this all the time. Families, or patients indeed, with inappropriate expectations of what their futures can hold. I think that with education and careful, compassionate presence, people can learn. The term in social work I learned as part of my theology classes at AST is acceptance. And acceptance and commitment are the things that people need to learn. To accept their suffering, to come to terms with it. They may not be able to fix it. It's like the serenity prayer. God, grant me the serenity to accept those things that I cannot change, the courage to change those that I can, and the wisdom to know the difference. And the acceptance of life's challenges, life's suffering, but learning to make more of the commitment to what's really important in life, which nearly always comes down to family and friends. And if we can accept that we're not fully healthy, we're not incredibly beautiful or rich or whatever it might be that society tells us we're supposed to be, that we suffer, we have chronic symptoms of this, that, or the other type, but we're going to get on with our lives anyhow. We're going to learn to accept and live with our suffering and still live meaningful lives with the help and support of our community, our family, our friends. And they will be living their lives more fully and authentically by helping us in our needs. That's how no man, I hate the words, it's so exclusive, but it's 300 years ago, we have to excuse him, but no man is an island. We're all in this together. And when we think that it's just me and, well, we take photographs of ourselves now, don't we? 30 years ago, who would ever have thought of taking a photograph of themselves? If that isn't narcissistic, I don't know what is. But if it's just me, then I'm going to demand what I want for me, and I'm not going to ask anybody else. When I talk about suicide, I think of suicide as a failure, whether it's self-inflicted or physician-assisted, it's a failure. You never hear people say after suicides, oh, it was wonderful, she did it her way, he went the way he would have wanted to go on his own terms. People don't say that. They say, where did we fail? What did we do or fail to do that made that person's life so miserable that the only way that they could see to move forward was to kill themselves? I still firmly believe that physician-assisted suicide is also a failure. And sometimes I'll actually say that to people when they're thinking over this as one of their options. I will say to them, if you, at the end of the day, reach the conclusion that you just want to die, I will have failed in my responsibility to help you find meaning and comfort in your living, because that's what palliative care is about. That's what I'm supposed to be doing, to help you find that meaning and that comfort in your suffering. That's where it comes from. And so suicide of any sort is, we've all failed when that happens.
Thank you, Philip. We still have a few more questions. I know we've reached the 8:30. Philip has said he's willing to go on as questions are relevant and still coming. So just want to let people know that some people have said they've had to slip out, and so that's perfectly fine.
Well, thank everyone for these wonderful questions. This is great discussion.
I would like to say I do have an anonymous comment in front of me that isn't really, it's a comment, not a question, and it's more of one where I would love to connect you with someone locally to help you walk through this situation that you're in. And so if you're still around and would like to message me with your info, I'd like to connect you and help you out in a more appropriate way than before. Philip, as we've been talking about advanced dementia and things, one question comes in. As it stands right now, is it possible that a family member who has been given power of attorney for personal care, can they request for MAiD over the family member that they're looking after?
Not if the family member is still able to speak for themselves. The substitute decision maker's power only kicks in when the individual can no longer speak for themselves. And then we say, what do you think your relative would have wanted under these circumstances? Right. And you just hope that they've had that conversation and that we have an advance directive where that's been considered.
Do you think there's a rise in numbers regarding medically assisted assistance in dying because we're seeing a rise in people doing pre-planning, end-of-life conversations, programs, those types of things? Do you think there's a correlation?
I honestly don't know, Sean. There are so many possible reasons, but we have no evidence to base any conclusions upon at the moment. The future reports, these annual reports on medical assistance in dying in Canada, the first one we had from 2019, future reports, they have been instructed to give much more information because it is recognized that those documented numbers only include the numbers of people that made a written request. So those people who just said to their caregivers, I'm thinking about MAiD, or I want you to see whether I can be approved for MAiD. If it doesn't get documented or doesn't proceed, they're not even captured in those statistics. So the statistics may be wildly inaccurate, but also they have been directed to include more demographics than just which province, what diagnosis, how many of the requests are actually carried through. They're looking at more subtle sociological data like racial origin, like socioeconomic status, those sort of factors that may, we fear, influence people to make a decision and feel coerced into making it for whatever reason. Either because they feel family pressure, or because they have financial pressure, or because they feel that they're not being cared for in some way. But I don't think we have enough information. It's too early to be able to make those conclusions with evidence.
Do you think there is any comparison when someone is on life support, very little possibility of living consciously without machines moving them? Is this in the same category as, when families get to the place of saying, what we, crassly term pulling the plug? Are these two things in the same boat, for lack of a better illustration?
No, they're completely different, because that person's dying. We're not ending their lives. They're dying, and I don't want to actively end someone's life, but I also do not want to prolong their death as a palliative care physician. So if somebody's dying, I have to accept that as much as the family has to accept that. And what we do is not intended to prolong their death. If we can prolong their life, that's fine. But if we're just prolonging their death and their misery, then that's not good palliative care. And as I said just a moment ago, we've always had ways of avoiding unnecessary suffering by passively discontinuing interventions which might prolong the suffering or prolong the dying process. So pulling back on medications, switching off ventilators if somebody is showing no signs of brain activity and a likelihood of ever being able to breathe spontaneously again. We do those things in a passive way of stopping doing stuff rather than actively intervening to end the life. And so what we no longer in palliative care talk about DNR, do not resuscitate. We refer to AND, allow natural death. We can accept that the death is a natural process and we're allowing it to happen. We're not making it happen actively, we are passively allowing it to happen. And while it's happening, we're doing everything possible to keep that individual and their family comfortable and relieve suffering. It just comes into my mind now talking about people on ventilators in beds. One of the things that I love about palliative care is, and this happens very frequently, the dynamic where you have the person who's in the bed, usually unresponsive, getting close to the end of their lives. And we're actually not too interested in what's going on with them because they're comfortable and they're dying. But I look around the bed at the family and see how they are reacting. And I love to see children in that context. And I love to see reconciliation from families who've been separated coming back together in that context. And I know, because I've heard it from many people years or months later, that those are sacred moments in those families' lives. Sometimes people will say something crass like, "This is really inconvenient. I need to get back to Fort McMurray. Is there nothing you can do to hurry this process up?" To which I reply, no, there isn't actually, and it may take a while, so relax and get used to it. This is a timeless place. We have no control over the end result or when it's going to happen. So just sit and enjoy being with your family and being with your dying relative who can probably still hear what you're saying. And just be here and enjoy that presence. And that's where memories are made. That's where people really come together as families. And that's soul-making stuff going on right there. And that person's not dying alone. This is not the atomistic approach to life. But that's one of the hugely rewarding aspects of palliative care, is being able to be part of these wonderful moments where people come together as family around a deathbed. Mm-hmm. And they will never forget those experiences. I know when I see children wide-eyed at a deathbed, often much more at ease than their parents with what's going on, it's a wonderful experience to be able to share. And I know that child will never forget that experience for the rest of their lives. And it won't necessarily be a scary or a sad experience. It'll be something that they realize they've shared with their family as being part of a family.
And certainly, Philip, as we spoke the other night, I shared with you a couple of instances, and it can be such a privilege to be part of that journey, whether it's a family or a close friend, and to celebrate what was, and to also with the individual look forward to what we've been believing and hoping for and praying for, is what awaits them. And so that's a gift and a privilege when we can walk that with them.
Indeed.
One quick question that I don't know if it's a loaded one or not. We talked early on, there was a question about palliative care volunteers from the parish perspective. Are there things that we could be doing as church in terms of training our leaders, whether they're professional, on staff, clergy, or part of a volunteer pastoral care team? Are there ways we can be training our people better to work and be present to those in palliative care, in your opinion?
Yes, there are, and I've been happy to be part of some of that training. I think online today is my sister-in-law Joan Tufts down in Yarmouth County, whose Catholic parishes down there have a very active group of volunteers who've had me go down and do palliative care teaching sessions on several occasions over the last few years. The problem at the moment is we can't use any of our palliative care volunteers because they're not allowed in the hospital
Right.
during COVID. So that really is a sadness. We have some who are allowed to come in to bake and to be in the family room just to support families, but we have a bunch of wonderful volunteers who want to come and help and support families around the time of a death, and they're simply not able to. It's not just them, but it's the families themselves that are not able to be there for their dying parents at this time because of COVID, which is terribly difficult.
Mm-hmm. Do you think or foresee that there will be a conflict of interest in you being both a palliative care doctor and a minister?
I actually think that they work very, very nicely together. And I see the palliative care as having catalyzed my discernment of a calling to ordain ministry.
Mm.
If I'd still been doing surgery, I don't think I would have moved in this direction. But having the opportunity to be close participant with families who are facing their mortality, and the privileged position that you just mentioned a moment ago, Sean, and dealing with the more spiritual and pastoral aspects of palliative care, I think that was what awakened in me the desire and the motivation to move from being an active church member to being a postulant. And I think that they are very complementary. But having said that, I have to keep them separate. I wear many different hats already, and I have to keep those hats quite separate. I have to emphasize to people sometimes, I'm not actually your priest, I'm your palliative care physician, or I'm seeing you in a pastoral role and I'm not your doctor. And we need to keep the roles quite clear, but there is a huge amount of overlap. There's a huge amount of overlap.
Wow. I'm going to invite Nancy back in a second. Just want to, again, if the individual who made the comment about their own journey is still with us and would like someone to make contact with them, please reach out to me. You can respond to the link invitation and confirmation of your registration, and I will do everything I can to walk with you in that process and connect you with someone locally. Thank you, Philip. Nancy.
Yes, I do want to thank you, Dr. Cooper, so much for your presentation this evening, and definitely a lot to think about and a lot of good information. Thank you for also giving of your time to answer lots of questions. And so we just want to thank you again, and also mention that for those of you who have tuned into this, we hope to organize another Christian forum sometime in the fall. So you will probably get some notification of that at some point as well. So again, thank you so much.
Thank you, Nancy. Thank you again, Philip. It's been great to be with you. And it's been great to have everyone from it seems like almost all over the country with us again. And so it has been great to be with you and to share with you. Thank you all for the questions. Again, the recording will be uploaded to the Diocese of Fredericton's website, likely by midday tomorrow. If you'd like to share it with someone who you think could benefit from the teaching, you'll find it there.
Thank you all for participating and being such great questions as well. That was lovely. It was a really good, I felt a good dialogue was had. Thank you. God bless you all.
Thank you, and blessings everyone. And it's been great to be with you. Blessings.
Good night.
See you.